Thank you for that introduction. It seems like a splendid event, and it's a real honour for myself and my colleague Emma, who will introduce herself in a few moments, to be invited to speak today. As we just heard, I've been working at the General Medical Council for the last year. I'm a doctor in training. I hope in the next 45 minutes or so, Emma and I are able to demonstrate a variety of journey that you can go on if you embark on a career in medicine, and we hope to kind of inspire you about some of the opportunities that might be out there, and motivate you a little bit to think about some of the behaviours that are expected of you when you join the medical profession, because I think it's never too early to start thinking about those things. So let's move on. So we're going to say a little bit about us, about the journey that we've been on, the things we've been getting up to, just to kind of make our story come to life, so to speak. We're also going to talk a little bit. I'm going to talk a little bit about the General Medical Council, which is the professional regulator of doctors, and you don't need to know heaps about the GMC, but more important really is the duties of a doctor and the behaviours that are expected of someone when they're a doctor, someone when they're at medical school, and then perhaps someone who's thinking about joining the profession. And I think that's the bit that's most relevant. And then my colleague Emma is going to talk about some cases, things that you encounter every day as a doctor, and some of these are going to have an ethical and a moral dimension, which is and hopefully you'll realise that one of the fascinating things about medicine is that it's very rarely black and white. It's very rarely right or wrong, and there's lots of grey, and that's what makes medicine so very interesting. So a little bit about me. So I'm a doctor in training in anaesthesia and intensive care medicine. So I spend my time looking after people when they're having operations, or people when they're very poorly in the hospital. I prefer pictures. That's how I function. So these are some photographs that kind of depict some of my career so far. So I went to medical school at the start of this century, which makes me sound very old. I went to medical school in 2003, getting on for 20 years ago. So I had a wonderful time at medical school. Did some got access. Did some amazing things. Spent some time in Africa doing sexual health education. Got to visit Norway. Got to visit New Zealand. Learned a great deal. The next photograph in the middle of the screen is an actual photograph of me when I was doing my foundation program. It's not actually a photograph of me when I did my foundation program, but you will see young doctors and people do indeed look very young. And when I started my foundation program in 2008, I then realised that my journey into medicine was certainly not over, and it was only just beginning. So medical school really is just the first step, is what I'm trying to say. The next photograph in the top right hand corner, the beautiful sunrise, is a photograph that I took when I'd been to work in. I went to work in New Zealand for a year, having worked in the UK for 2 years. It's a photograph. Not many UK hospitals have views such as this. I'm sad to say. It's a photograph from the 10th floor of North Shore Hospital in Takapuna on North Island in New Zealand. and I had a wonderful time working out in New Zealand. Made lots of friends, and learned a lot of medicine. And when I was out there, it's when I realised that the thing I enjoyed most about medicine was looking after poorly people. So when I came back from New Zealand, although we were tempted to stay, I embarked upon training in anaesthesia and intensive care medicine. And the photograph in the bottom right-hand corner, that shiny building, is the Royal College of Anaesthetists in London. And I spent the next bunch of years attending buildings such as that, doing postgraduate professional exams in the Royal College of Physicians, Royal College of Anaesthetists, Faculty of Intensive Care Medicine. So really spent years learning about anaesthesia and intensive care, and that's the journey I'm still on. So the photograph in the bottom left-hand corner is an intensive care unit. It's unusual, this photograph, because it has no patients in it. And that is unusual for an intensive care unit, as you may well imagine. And that is where I spend most of my time these days, including next week, I'll be on our coronavirus intensive care unit at the University Hospital Birmingham, which I'll come to. So how did I come to speak to you today? Well, during the course of my career, I developed an interest in leadership, and to kind of to demonstrate some of the things you can do, I applied and was selected for a national fellowship in leadership, where I went to work for the National Medical Director, which was a fascinating time to do it, both with Brexit and then coronavirus. And in that time, I worked at the General Medical Council, which is a non-clinical role. And if someone said to me when I went to medical school that I'd have spent a year working in an office or traveling around the UK, not actually doing clinical medicine as part of my clinical career, I would have thought that you were mad. But it was a fantastic, and has been a really eye-opening experience. And there are a number of different opportunities you have when you enter a career in medicine. So as I said, I now work at University Hospital Birmingham. So it's the big shiny building in Edgbaston in Birmingham. The whole second floor of this building is the intensive care unit. It's the largest single site ITU in Europe, and it's where I'll be next week, looking after some patients who are suffering badly with coronavirus. So hopefully that gives you a bit of a flavour of my background and how I've come to be here today, having spent a year working at the General Medical Council. So I'm going to talk to you about the General Medical Council. I don't think you need to know heaps about it, but more importantly, the duties of a doctor. Why it's important? I mean, I think the behaviour that you exhibit as a medical professional and as a doctor is the essence of medicine. The duty that you have. I do acknowledge that clinical skills and knowledge are very, very important, but without appropriate professional conduct and how you behave with patients, those clinical skills are become less important if you're not able to get that bit right first. And I would encourage anyone considering a career in medicine to try modelling the best behaviour they possibly can, because it's one that will be expected of you but when you join the medical profession. So the General Medical Council, a bit about them. Our primary aim at the General Medical Council is to protect patients. The organisation is a patient safety organisation, and they are there to look out for all of us, the public. They are not there to represent or protect doctors in any way. They're there to keep the public safe, and that is the essence of what they are. At the GMC, they are there to protect patients, but increasingly are trying to do so by finding ways to support the medical profession, whether that's through guidance or documents aimed at advising the profession what to do in certain situations, or whether that's commissioning reports into important areas of practice or workplace, or looking into the workforce. But predominantly, the General Medical Council that is there to protect patients. And they take that very, very seriously. So the actual aim, because the General Medical Council is written into law, the Medical Act in 1983 says that the GMC should protect, promote, and maintain the health and safety of the public. And they do that in a number of ways, and I'll come on to that in the coming slides. But predominantly, they do that by deciding who can be a doctor and who should no longer be a doctor, and what standards they must meet. Your interaction with the General Medical Council, most people in the medical profession don't want any interaction with the General Medical Council. Your interaction when you go to medical school will be one when you finish your medical degree, you've passed the final exams, and when everyone listening to this call, there will most likely be a medical licensing assessment at the end of your medical degree. When that's completed, you will get provisional registration with the General Medical Council, so your name will appear on the list of medical practitioners. Following 1 year of successful practice in the foundation program, you're providing that everything's been successful on that journey, that you will get full registration with the GMC. You'll appear as a full registration. Most doctors then go on to have some form of specialist training, either in secondary care or in general practice, and you, after that period of training, join the specialist or the GP register. So that's what most people's interaction is with the GMC when they think of their GMC interaction. So I said the GMC is there to keep patients safe. And they do this in a number of ways. And the most important one is in the center of this picture, which is the standards, the professional standards that they set. Now, and these are largely around behavior. And the standards that are set are largely standards that the profession expects of itself. So they're not most of the standards are not unreasonable, and doctors will believe that they should behave in the way that are set out in the standards. That they're not unrealistic or unattainable, and it's the essence of how you behave once you're a doctor. So they keep people safe by setting those standards. They, on the left hand side of the picture, is registration. So they decide who can be a doctor. So who can get their name on the medical register. And they also decide if someone's behaviour is poor or their practice is called into question. The purple tab at the bottom is fitness to practice. So the General Medical Council may look into your the way you've behaved or things that you've done, and if your behaviour is not up to scratch, in very rare cases, you cease to be able to work as a doctor, and they remove from the register. Revalidation, don't need to worry too much about. That's just about keeping doctors need to proving they're up to date every 5 years or so. Most relevant to everyone listening to this call is probably the education tab at the top. So the GMC approves all new medical schools, approves all their curricula and the assessments they use at the end of that. And they also set postgraduate curricula, so the training schemes through which I go in order to get onto the specialist register. So within that education is where you those standards that I talked about are instilled. So very much the standards set here by the GMC are ones that you will learn whilst at medical school. So the GMC sets a bunch of standards. You don't need to know much about this, other than that guidance exists for lots of area of practice. I think important things are consent, confidentiality, leadership, how you deal with children, raising and acting upon concerns about patient safety. And there are, as you can see at the bottom, there are 32 pieces of guidance in total. But the most prominent ones are the ones that are at the top. there is one piece of guidance that really stands out amongst all of them, which I would indeed encourage you to read, and it's good medical practice. So it's the core piece of guidance that the medical regulator writes about the medical profession. Now, anyone who's thinking about a career in medicine, I would encourage you to read this document. It's free. It's on the website. Just type in "Good Medical Practice GMC." It's a document that was published in 2013. It has 80 sentences or short paragraphs, and those so it probably will take you, I would think, less than 15 minutes to read. It's very easy to read because it's written at the a reading age of approximately 12, because it's written for the public predominantly, and it's what the public can expect of doctors. And there's some core things within it. I'll just talk about a couple. So trust, so showing respect for patients, treating patients and colleagues fairly and without discrimination, acting honestly and with integrity. It talks about keeping up to date and about responding to risks to patient safety. It talks about your duty to teach others and to train and support one another. It talks about establishing partnerships with patients and treating them without discrimination. And it talks about applying your knowledge and skills into practice. So they're all very all the paragraphs within Good Medical Practice are very easy to understand, and I'd encourage you to read them, because for me it's the absolute essence of being a doctor. So I'm just going to I'm not going to bore you with the whole document, but I'm just going to take one paragraph out of it, which is the first one, and I'm going to read it aloud, because I think this really sums up what it means to be a doctor. So patients need good doctors. Good doctors make the care of their patients their first concern. They are competent to keep their knowledge and skills up to date. They establish and maintain good relationships with patients and colleagues. They are honest and trustworthy and act with integrity and within the law. And for me, that is a really great start when you think about the way that doctors should behave, and the way that people entering the profession should think about behavior. So what's the point of all this? Is that the point of all this is that in order for doctors to be able to treat patients, and patients must be able to trust their doctors, it's extremely important. Patients, it's an absolute privilege to be a doctor. The patients will tell you things that they are, I don't use the word secret, but they are their innermost thoughts, things that they may not necessarily tell their mother, brother, father, spouse, wife, son, daughter, or best friend. It's a huge privilege, and you have to treat that information with the utmost respect, and it's extremely important for that relationship with the patient to maintain that confidentiality and the respect for what they're telling you. So some of the trust for the medical profession comes from, or most of the trust comes from the way the profession behaves, and the fact that we have a professional regulator which keeps tabs on the performance of doctors. So is it effective? So I'll be interested to know who they think the most trusted profession is in the UK. And sadly, it isn't doctors. So if you asked the public to say who they trust to tell the truth, doctors do very well, but they are beaten by nurses. So both are trusted professions. Both have professional regulators. Teachers, judges, and scientists also well trusted. And that we have to keep being trusted as a profession. That's extremely important. And when you go to medical school, the public will expect the same levels of behaviour from people from medical students, because it becomes blurry between medical student and doctor. So it's extremely important. Just for fun, who do we think are the least trusted professions? So there's so this is from Ipsos Mori. They're a polling company which the GMC used in a few years ago, and no surprises. Estate agents, journalists, professional footballers, interestingly, government ministers and politicians. So compared to those, we are favourably trusted. No surprises there though. So what makes a good doctor? The public were asked things that made their doctor good. And many of the things that come out of this, which I'll display in a word cloud, are not things that are necessarily clinical, as in my GP knows 100 causes of X, Y, Z, or my cardiologist knows lots of causes of, or is very good at this practical procedure. When you ask the public, most of the things they want from their doctor, the clinical competence is generally accepted, but it's generally behavior things. So things that are a duty of a doctor. Someone that listens, that has compassion, that's treated with dignity, that's kind, caring, human, and acts honestly. Which are all things which are predominantly behavior rather than clinical. So behavior is extremely important. So professional behavior. So doctors are held in a trusted position, and they must make sure their conduct justifies the patient's trust in them. Now, as a medical student, and you're aiming to join this trusted profession, you have to meet higher standards of behavior than other students. And I would say we should be careful about the way we behave in the lead up to medical school. And things I'm talking about are things that you might not necessarily think matter now, but they might matter when you're at medical school. I think people should be a little cautious with their things like plagiarism, marking attendance, making sure you're completely honest with what you do. Being trustworthy is extremely important. Social media is a bit of a minefield, but certainly if you're a medical student and you use social media and you have and you share or comment on things which are discriminatory, that will cause problems for you when you're at medical school. So this is an issue that I think is extremely important, and it's extremely important for patients' trust in the medical profession. So that was a whistle-stop tour, really, of who the General Medical Council are. They're the people that set the standards we must adhere to, and the duty of a doctor to the duties that exist of being a doctor. I'm now going to hand over to my colleague, Dr. Emma Roche, who's going to take us through some cases that might illustrate some of those points.
Thank you, Brendan. So we'll switch the screen sharing. So I think, Brendan, if you just stop sharing, then I'll open up on my screen, if that's okay. Thank you. And I noticed that people are typing some answers in the chat box. So if you want to keep doing that, then please do. That would be really helpful. So I'm Emma. I am a paediatric intensive care doctor, and really pleased to come and speak to you all today. So again, a little about me to start with, and coming back to our aim of hoping to show you the different kinds of opportunities that medicine can give you. So the picture on the left is me at graduation. I started medical school in 2004 and finished in 2010. So medical school was 6 years for me. And that's because I took an extra year to do an integrated BSc in psychology, which is something that a lot of people do in medical school. And that's an opportunity to study something else in depth for around a year, And you can do that in a whole range of subjects. So I did psychology, but I have friends who looked at things like sports medicine. There are languages, ethics, lots of different things that you can also study even whilst at medical school. I started my paediatric training after foundation years, and I have now been a doctor for 10 years this summer. Whilst doing my general paediatric training, I took 6 months out to go to work in Myanmar with the Royal College of Paediatrics and Child Health. They have a volunteer program at the college where you go and work clinically in a fairly remote hospital, doing a lot of teaching as well and a lot of project work. And that was really, really rewarding. Very interesting to work in a low resource setting. It means that you need to rely on your clinical skills a lot more than tests and investigations. And then just thinking about the ethics and challenges of working somewhere where they don't have electricity, and things like your light therapy for children who have jaundice, or certain types of oxygen therapy, which will just stop working in the middle of the night when power cuts come. So very interesting, very, very challenging environment to work in. But being a doctor gives you that opportunity to work throughout the world. Your skills are so very transferable, and there will always be a need for all medical professionals, doctors and other professionals. And so then I've actually moved into a specialty within a specialty. So I now work in paediatric intensive care, which is within paediatrics. So we look after very, very small babies, sometimes premature babies as small as 600 grams, up until teenagers. And similarly to Brendan, we look after the most poorly patients in our unit in Birmingham. Something else that is super rewarding as a career. It's really nice, especially when we have patients who've been sick for a long time and then they come off their ventilator and they're smiling at you, and that's really special and another privilege of being a doctor. It is very hard work though, so it's a lot of night shifts and a lot of long days, and often leaves me feeling quite tired. So I'd also done the same leadership program as Brendan last year at the General Medical Council. So I worked in the strategy team of the General Medical Council. And I suppose it was partly some of the work in Myanmar that drove me to being interested in leadership, because when you think about how a healthcare system works in its entirety and how it's led and managed, then that's kind of led me to think about leadership. And so I spent the last year with the strategy team at the GMC, and we did lots of different interesting work, and did things like visiting Parliament, visiting all the different healthcare organisations to find out what they do, and getting involved with national policy. So I hope that gives you an idea about the different things that you can do within medicine, and those are just a really small area, I suppose. There are reams and reams of different things if you're interested in to go down with a medical career. So Brendan talked about trust, and we're going to run through some case studies now that will bring those ideas to life with a story. And we said that trust is a really important part of being a doctor, and this is the confidentiality guidance from the GMC. And that is obviously really important, so that patients can share information with you. If they think that their information is safe with you, then they're more likely to divulge things that can help you to look after them and help you to come to a diagnosis. There are obviously occasions where information needs to be shared. So we work across different hospitals into GP surgeries. Sometimes information needs to be shared with organisations such as social services, for example, thinking about especially in paediatrics. So confidentiality and trust are very, very important. But as we also alluded to, things are not always black and white. And hopefully some of these case studies will get you thinking a little bit about that. So this first case study is about Dr. McDonald, and she works in an emergency department, and the paramedic, Craig, has just brought in a patient. So the patient is a 19-year-old man, and he has been found with a stab wound to his abdomen. The paramedic tells the doctor that he found the patient near a multi-storey car park, and that the phone call to the ambulance had been an anonymous phone call. but that they noticed there'd been several other incidents in the area recently, and the paramedics had become quite worried about gangs and crime that's associated in that area. They have a conversation about whether they should actually tell the police about this, but the doctor is worried about that trusting relationship and any effect that that might have on other people seeking help if they were to be in the same situation. And as we've already mentioned, the care of the patient is the first concern, and I think really important to have a look at the document that Brendan had showed. So feel free to type in the chat box here a letter, A, B, or C. So what should the doctor do in this situation? Should the doctor tell the patient that she doesn't believe him and that she's going to tell the police and then contact the police and give them the patient's details? Or B, tell the police about the knife injury and the suspicion that it might be an attack, but don't give them the patient's identity? Or C, agree that she won't inform the police so that he'll stay? So we've got lots of B's here, which is absolutely the correct answer. So the police need to be told about where and when the incident occurred, but absolutely the patient details do not need to be shared at this stage at all. A may be partly correct in that it would be ideal to tell the patient that you're going to contact the police, but not about giving or sharing the patient's details. And then C, because of the risk to others, then that is not correct. So the GMC guidance, which is specifically related to this, is that if it's probable that a crime is being committed, then the police will ask for more information. It's best to have the patient's consent before disclosing information, unless, and there are a couple of caveats, the information shared might put you or others at risk of serious harm, or if there's something related to prevention, detection, or prosecution of a crime. It sometimes happens that patients may come into an emergency department unconscious, or there are other reasons for which they can't give consent. And in those cases, information can be disclosed if it's required by law, or for example, if it's in the public interest to be sharing that information. So the next bit of this case study is that the patient's now been admitted to the ward, but the police have come and they really want to speak to the patient. They are wanting to know the identity of the patient and what injuries the patient has, and think that there needs to be a special case made because of the risk to other people. The doctor again says that she's worried about sharing the information and that other young people who may be involved in gang crime wouldn't be likely to come and seek help should they need it. But the police in this situation are really worried about the risk to other people that there might be. So again, what should the doctor do in this situation? We have an A, which is about encouraging the patient to speak to the police, a B, which is about just letting the police in to see the patient, and a C, which is about respecting the patient's confidentiality and tell the police that there's no further information. So lots of A's here. Okie doke. Yep. So A. So encourage the patient to talk to the police. The police have expressed in this situation that they really do believe that there's a risk to other people, and so it may be that disclosure is justified. B and C certainly aren't right. Even if the patient refused to speak to the police, then that still means that you could go ahead and speak to the police and disclose some information if that was necessary for public interest. And C, it is always a finely balanced judgment and it can be very difficult, but the police have identified a risk there, so it would be important to address that for the public. And so the guidance that's related to this is that disclosures in the public interest might be justified. And that's when there may be a risk of serious harm to someone other than the patient. This doesn't quite apply just to the patient though. So you should not usually disclose information against the wishes of an adult patient who has capacity if they are the only person at risk of serious harm. And then coming back again, as we mentioned before, if it's related to a crime, then information can be disclosed in the public interest. So that was a little bit about confidentiality, and we'll talk about another case study for consent right now, which is another one of the GMC guidance. So this is about speaking to patients and seeking their consent for diagnosis, prognosis, treatment, any decisions about care, and doing so in a way that is best for the patient, that respects their decisions, and makes sure that they have the capacity to be making decisions. So in this case, there's a 75-year-old gentleman called Mr. Hartley and his daughter Clementine, who've come to see the GP, Dr. Singh. So Mr. Hartley is 75 and he was diagnosed with Alzheimer's about a year ago. And he lives on his own, but he's struggling increasingly and sometimes can be a little bit confused. His daughter's becoming quite worried about how he's going to manage at home on his own. And Mr. Hartley's been having a lot of stomach pain, which is why they've come to see the GP today. The GP, after having taken his history, thinks that he needs an ultrasound scan in the hospital. So the GP explains this to Mr. Hartley, but Mr. Hartley is really insistent that he doesn't want to go to the hospital, that he's very worried. His wife had died there last year, and he's quite scared of going in. But his daughter, on the opposite hand, is very, very insistent that he has to have the scan, and just says to the doctor, just book it anyway. So what should the GP do in this situation? So shall we refer with the daughter's consent? Should we speak to Mr. Hartley and see if he's got the capacity to consent and then think about his decision? Or should we decide that because of the Alzheimer's, then we'll just refer him for the scan anyway? So as we're saying in here, yep, unanimously, mostly, we've got B's and one C in there. So yep, the GP in this situation has a chat with the patient and explores the issues with him and gets his consent to go forward with the investigation. So when speaking to patients and thinking about things like this, we come from the position that all patients have the capacity to make decisions about their care. They can decide to give or not give consent for any examination or investigation or treatment. And the thing about consent is that patients, when you're assessing capacity, you need to think about helping the patient to understand the information in a way that's helpful for them. And patients need to be able to understand, retain, weigh up, and communicate their wishes in relation to giving consent for any investigations. And it's important that patients are not assumed to lack capacity, for example, because of an age, disability, behaviour or appearance, any other beliefs that they might have. Or sometimes what happens is due to certain medical conditions, patients aren't able to communicate. And in all of these, we should never assume that a patient lacks capacity. And there are certain tests that you can do to go through those things with a patient. And obviously, I suppose an example in paediatrics of when a patient can consent for one thing but not another would be, some things are very, very simple. So in paediatrics, a young patient may be able to consent very easily for a blood test, but to consent for something more complicated like surgery, then we would involve their parents. And so consent is not a straightforward yes or no, it's very situation dependent, and it also is something that might change over time as well. So it's important to keep coming back to it. It's also important to think about how to support the patients better to be able to make a decision. So do we need to make sure that it's the right time and place to give the information? Can we give written information? Can we ask those close to them how best to communicate, or have a friend or family present to support them through it? So thinking still a little bit about consent and capacity. Unfortunately, Mr. Hartley develops a really severe pain in the middle of the night and has to phone the ambulance before he's gone for his scan. And when he gets to the hospital, he's very confused. And his daughter finds out from a neighbour what's happened. And she goes to the hospital to find out some information. And she speaks to the doctor on the desk. And the doctor says, who are you? What have you come for? And she explains that she's the patient's daughter and she'd like some more information. And the question here is about how much information to share. And in this scenario, the patient's now quite confused. His pain is better, but he's gone to sleep. And he's had an ultrasound scan in the meantime. So what should the doctor do, a different doctor on the ward this time? Should she refuse to give any information to the daughter in this situation? Should she suggest that, that the daughter comes back in the morning to discuss, or should she answer all the questions that are given there? Yeah, so lots of Bs. So, and a couple of Cs there as well. I think it becomes a little bit trickier. And the thing with giving information is that you've always got people to ask. You can always ask the consultant, and that's a really important thing to remember for an entire medical career, that there is always somebody else to ask. And that's often in the interest of patient safety that those conversations are held. And in this situation, we've now got a gentleman who's become quite confused as well. So the doctor in this situation shares some information that he's now comfortable and he was in pain, but he's had an ultrasound scan and it's been shown that he has an ulcer. And she suggested that he comes back in the morning. And so I think perhaps a little bit more information was shared here than we might have suggested from some of the answers that were given in the chat box. And the guidance that's related here is that it's important to find out from patients what information they would want to be shared. And it's good to get that in advance, because if there's fluctuating or changing capacity, then you know what the situation is to start with. But then importantly, if the patient now lacks capacity, you should share relevant information and assume that it's reasonable patients would want those closest to them to be kept informed of their general condition. So things are, as we said earlier, are not black and white. They can be very finely balanced, and these decisions can be tricky. And then the final case that we're going to talk through isn't so much about consent or confidentiality, but it's about wider patient safety issues and your responsibilities as a doctor to make the care of the patient in front of you your first concern, but also to make sure that general patient safety and those that you work with are qualified to do what they're doing, that they are being supported. So thinking about patient safety, you must promote and encourage a culture that allows staff to raise concerns openly. And the raising concerns bit is really important. And you may have read in your preparations for medical school kind of recent reports about raising concerns. So this case study is about a new consultant who is just heading home for the evening, and then she walks past one of her patients' beds, Mr. Johnson, and he's just been discharged from intensive care, and she noticed that he's got his food in front of him and he hasn't eaten or drunk. It doesn't look like from his dinner today. So she stops to speak to him and notices that he's looking quite weak, and she asks him when he last ate. He doesn't quite remember. He thinks maybe his wife helped him to eat his food yesterday, but they usually just take his food away before he's finished with it. And so the doctor wonders what she should do in this situation. So I'll give you a second to read those and then scribble your answers in the chat box again. So I think we have a whole range here of A's, B's, C's, and D's. So it's a slight trick question, because one of the answers is correct and two of them are partly correct. So I suppose the most correct answer is the fourth one, which is D, find a nurse and ask them to help the patient to eat his breakfast. And the doctor would do that after checking that the patient was actually safe to eat. So checking things like a swallowing assessment, checking that their diet was actually correct, and then speaking to the nurses. Yes, A can also be correct, but this feeding patients isn't really the role of the consultant, and also it's a very short-term solution. So while she might be able to help then and there, that's not going to be something that the doctor is going to be able to continue to help with, although it would be helpful in the situation. And then B, absolutely, this is going to be helpful for longer-term management of the situation, but won't actually help in the short term. And then C is not going to be appropriate, because once you've left and not managed the situation, then you don't know what's going to happen to that patient. And so the doctor the next day has a chat with some of her colleagues, and they notice that they've raised some other concerns about patient care around the ward in general. And they decide, as a multidisciplinary team with the doctors, nurses, physiotherapists, etc., to start running some audits on basic care standards around the ward. And so the GMC guidance that relates to this is about being responsible for supervising staff and knowing what your responsibilities are and being able to give clear instructions to people who you work with. Being able to offer proper support and being sure that the other people who you supervise have the necessary knowledge, skills, and training to carry out their role. And that's from the Leadership and Management GMC guidance. And so those are our 3 short case studies, which I hope give you a little bit of insight and something to think about. Thank you for being so interactive with the chat box. It's difficult sometimes when you're online to know if people are there, but thank you so much for engaging. I really appreciate that. So, shall we open up the floor for questions?
Right, okay, thanks for that, Emma and Brendan. That's been really, really useful. And it just illustrates the point. What the last few questions is what you'll come across shortly as what we described as situational judgment. The first you'll probably come across is in your UCAT exams, which Dr. Mann will go through shortly. There's not always a right and wrong. There's they split things up into what's the most appropriate but not ideal. There's not always 100% one correct answer for everything. Let's look at some questions. There's very interesting questions here. I don't know if any of them are related to the GMC though. So either Brendan or Emma, when you were at medical school, did you have time to enjoy yourselves with friends and chill out?
I'll answer that. I'm sure Emma will. So, absolutely. We worked hard and we played hard. I've never had so much energy, I think, than when I was at medical school. So spent a lot of time learning, and I personally really enjoyed the amount of knowledge and skills that you develop over the 5-6 years you're at medical school, and you kind of build on it every year. But at the same time, because you're there for quite a long time, you've got a real opportunity to develop friendships that will probably last a lifetime, or certainly last your career. So you have a real opportunity to get involved, get your teeth into life at university, whether that's extracurricular activities or things within the medical school and sports societies, dramatics, things like that. There's so much opportunity. I think medical school makes that even longer. I don't know if Emma's got any comments.
Yeah, there's definitely time to enjoy yourself, make lots of friends, have a lot of fun. I mean, it's definitely busier than other courses. My best friend did a history degree, and I'd often go out to the hospital, to the GP in the morning for the day, and come back and still find us sitting on the sofa, hadn't moved all day long. So it's very different, but that doesn't mean that there's not time for having a lot of fun as well.
Okay, yeah, good. I mean, from my experience, the first 2 years at medical school, when you were actually based in the university and you were on campus, were really enjoyable. You got involved in university life. Once you started in year 3 and you started going out into the hospitals, things started to get very tough. But yeah, it was enjoyable all the way through. But yeah, you've got to maintain a good work-life balance throughout your career. We don't want anybody being burnt out.
Mm-hmm. And that's really important, a good work-life balance and not getting burnt out.
Okay, so another interesting question here. There's some concern, whether it's a concern, does the existing, as I presume, social media presence affect the ability to get into medical school? So I suppose what's being asked here is if you've got social media, perhaps at college, is that going to affect your ability to get into medical school in some way?
Well, I don't think we speak for the medical schools who are the ones that set the admission criteria. But I would say, as advice to anybody who's thinking of entering the profession, only put on social media is things that you'd be prepared to say in public, because it is a public forum, and it will be saved. So there are no doubt doctors and medical students who maybe get into trouble each year for promoting or saying things on social media that may undermine the public's trust in the profession. That said, you are, as a doctor, as anyone else is, you are entitled to your own opinions. But if those opinions, and you're allowed to protest, you're allowed to speak your mind. But if you're if those opinions or things you say undermine the public's trust in the profession, for example, saying that, I don't know, coronavirus is caused by mobile phone masks, that undermines the public's trust in the profession. So I would be cautious about what you say. But many doctors have social media presence, and in fact, actually, it is actually really good 99% of the time, because it allows doctors, nurses, physios, dietitians to collaborate from all around the world and have engaging conversations about improving things and about developing educational resources and having good debates about the best way to do things. So I think largely social media is a positive thing, but I would just be sometimes cautious about it.
Another interesting question here. Can a patient refuse treatment if the doctor or nurse is from a particular race or background?
Sorry, can a doctor refuse?
Can a patient refuse treatment if the doctor is from a particular race or background? I think this is what it seems to be alluding to, is if patients saying that they only want to see a white doctor, or a doctor from a particular background, or.
So I think this is a really difficult area. I think generally the approach within the NHS is that we'll try and do our best for each patient, but the service doesn't exist whereby patients are able to choose the practitioners that they see. So if they want a male doctor or a female doctor, but there is only a male or a female, and then that applies. If the service can't accommodate it, then there is no capacity to choose. So generally speaking, that won't happen. Having said that, if somebody came to see you, and Emma and I were running a clinic together, and a patient wanted to see a male doctor or a female doctor, we would accommodate it on if possible, not on grounds of race, though.
It's a really tricky issue. I think it's good that a lot of NHS departments have signs up and a no tolerance policy for discrimination, and that's really important. And caring for NHS staff should really be at the forefront, and doctors and nurses should never be made to feel discriminated at work. I've never, fortunately, been in this difficult situation of having a patient refusing treatment, but it would certainly need to be getting much more senior people involved to speak to the individuals.
Another interesting question here. I don't know which particular job it's aimed at. Do you ever get bored of your job? And if so, what keeps you going? I don't know whether that's referring to your GMC job or whether you're referring to your hospital.
I think in the hospital it's impossible to get bored, really. Every single day is different. And also if you work in something like Brendan or I do, which is anaesthetics intensive care, it's always very, very busy. There are always lots of different situations going on, especially intensive care, lots of emergencies everywhere. It would be very hard to get bored. The GMC work is very different. It's very engaging on a brain level that's much more creative and thoughtful, equally interesting. But I don't think that is one very, very positive thing about medicine. I've never felt bored.
I would echo that. I would say the longer you do something, you think maybe emergency medicine is the most exciting place to work. But if you've done it for 10, 20, 30, 40 years, you probably end up seeing most things. So people will look in their careers to take on other roles, whether that's in education or leadership or charitable work, or so there are so many opportunities for a diverse career. And I don't think I've ever been bored at work, but there are days which are less exciting than others. But medicine's a fantastic career for variety.
Yeah,
is what I would say.
but we have chosen careers that are very intense.
Yeah, I agree. Medicine isn't boring. Here's an interesting question here. What if you're openly religious on social media, but don't impose your beliefs on patients? I think what it's getting at is okay, I may have a very strong religious views. For example, I may be practicing Catholic, or and then all the values that go with being that. So I'm very open about those on social media. But when it comes to my clinic, I don't impose that on my patients. I mean, what's your views on that?
Also a controversial area. So doctors are allowed personal beliefs, absolutely, and of course, many the medical workforce in the UK is extremely diverse. So we have representations from all sectors of society, and there are many doctors who practice many different religions, and there's absolutely no issue with that at all. The only thing we mustn't do as doctors is let our personal beliefs affect the way we treat patients. So as long as we don't push our personal beliefs upon the patients, and we should be neutral in that regard. Then we're giving the patients the right to make their own choices without having our inferences put on top of them. But you are absolutely allowed personal beliefs.
And lots of people share those on social media. It comes back to that idea about trusting the profession and things. Are you happy for everybody to see that once it's on social media? So I know lots of people who share religious beliefs on social media, and that isn't a problem as long as they aren't anything that's undermining trust in the medical profession.
There's a few questions here about which I think might be directed as your work in intensive care. Obviously it's very intriguing and interesting. I did a few months myself as a SHO in those days in intensive care. They're asking about, it seems to be asking about the work pattern. Is there nights, or is it extremely heavy in terms of workload? I mean, what's it like rota-wise nowadays working in intensive care?
So we're both still doctors in training, so things will be a bit different once we're consultants. So I do 1 weekend in 3, and I do a set of nights probably every 3 to 4 weeks or so. So that's 3 or 4 nights. But I have just had 7 days off, which is not annual leave, and that's just after doing a lot of shifts. So it depends what you like, really, and what suits you. The shifts are tough, and the burden of work on the shifts can often be very heavy, not just the hours that you're doing. It is difficult, but
it swings and roundabouts. So if you choose to work in anaesthesia intensive care, you can be working nights, and you'll be in the hospital at night. You until you retire, probably. If you work in general practice, people often forget they have very long days. Their clinics often running this evening, often having to work weekends. They don't have to work at night, but so there are varieties of careers you can have that will suit what you like, and whatever you do, it's going to be hard work, but that's the enjoyable side of it. So there's no easy line in medicine, I would say, wherever you end up working.
Or in life, I think, really, if something's worth doing, then it's probably not easy in general.
I think finally we've got a few questions that appear to be about capacity. So the first one is, when it comes to disclosing patients' information, do you ever come across any ethical issues, and how do you deal with them? And then something on the similar lines, patients disagreeing with the treatment, which would help perhaps a serious case, and how many, no matter however many times the patient just keeps on refusing that treatment. Is there another way that the doctor could kind of, do the treatment on them, or is it set in stone?
So nothing is set in stone as such. These situations are really hard and often need a lot of different people discussing things. So I work in pediatrics, so things are slightly different. We have guidance that's specifically for pediatrics. And it's not uncommon in pediatrics that, especially in pediatric intensive care, that parents would disagree with treatment plans. So you probably saw in the media various cases that came out about where parents have taken, or there have been court cases in relation to decisions about children in intensive care and withdrawal of treatment. So it's not uncommon. There are lots of different processes and procedures that support working through these things with families, ideally alongside them and together. But it's very much not uncommon that those kinds of situations would happen. There are Caldecott guarded, there's kind of we have safeguarding people that we speak to. We have family services who would support us through that. In the very extreme, sometimes legal services, but lots of different support through those difficult decisions.
I'll just say very quickly, I'll say that the starting position for all of this is that patients have the absolute right to decide what happens to them, even if we think, even if you might think as a doctor or nurse, it's not the right thing. They have the right, providing they understand all the information. And we would emphasize the understanding, make sure they've completely got it on board, but that you have the right to decide what happens to you. And we must respect that.
Okay. All right. I think we're going to be here forever because there's lots of interesting questions and topics that are coming up. I think what I'd like to do is thank Emma and Brendan for giving up their time on a Sunday, for giving us an excellent training session. It's only the beginning, folks. There's a lot more to good medical practice that you'll come across as time goes on. So Emma and Brendan, thanks. It's been an honor having you here, and that was a very good and informative talk.
Thank you.
Thank you very much indeed.
Thank you.
Thank you. Okay.
So thank you, Imran. Folks, you've heard Emma, you've heard Brendan speak to you about the good medical practice document and the duties of a doctor. References were made on those documents, and we always profess and talk about those documents as the foundation, as the bedrock of what it is at the heart of medicine. It's important that all our aspiring medics go onto that document. As Brendan said earlier on, it's very easily readable document, and I think it's been intentionally done so in that regard, because the idea is that Joe Public, everybody from society can access and understand really what medicine's all about. But the key there is, if we can understand what it is to be as a doctor and what it enshrines, then we can kind of purport that. We can express that in the way we practice, in the way we negotiate with our patients. And we're not, I guess people say, well, why should I know about all this? I'm only applying to medical school. I'm not a doctor yet. Surely this is something I'll pick up over time, in medical school and my junior doctor training days. And the analogy I give to our students is that, look, fine, if you want to compare yourself to, say, Brendan and Emma, who came on earlier on, as the so-called polished diamonds in a society, in the system, so to say. They've been through medical school. They are professionals in their own right. They're now working for the GMC. You can see them as the kind of polished diamonds in the system. They know about everything. Myself, Imran, and we've got Dr. Russell Robb with us now. We all kind of perhaps know about these rules and regulations back to front, and very much try to aspire and live to those ambitions on a day-to-day basis. But what we want from you as students, and as if parents are listening today, is our students are like the uncut, the rough, unpolished diamonds. We want to see that those innate qualities, abilities are there within our students. If we can, if you remember the scenarios that Emma discussed, you all could engage, and you can, by and large, you were getting the right answers. So you see, whilst you haven't even gone to medical school, those very values are enshrined in humanity, in kind of ethics that we aspire to and work towards as a human society. So it's not all that difficult to kind of, understand these principles. So it's very understandable why medical schools would want you to be aware and be able to navigate and understand and be able to articulate some of these points, whether it be something you bring across in your personal statements, whether it be something that you're able to discuss in the MMI interviews or panel interviews for that matter. So yeah, again, thanks for our speakers coming on earlier on from the General Medical Council. I'm going to